up here, and I'm good. I lied to you though. I do have a video that will have sound. I lied. I will own my lie. So I hope I didn't totally mess up here. All right. So thank you so much to the Planning Committee for inviting me to speak at this event. As Bill shared, I wear two hats. So I'm an administrator, EVIL Hospital Administration at the University of Iowa, which has, my purview has our ECMO perfusion cardiac surgery programs as part of the portfolio there. But then I also, pretty much right at the height of the pandemic, officially took a role with the Extracorporeal Life Support Organization to help them advance their educational missions, which I had been working and teaching for them for about 10 years before taking that on, so it wasn't a huge stretch or anything totally different than what I was doing other than taking on a true title there. So over the next 40 to 50 minutes, I hope to share a little bit about what I'm envisioning as the new era of ECMO education. The past few years, the evolution of ECMO has been tremendous. Time spent in quarantine was not wasted, and while I didn't quite master the art of doing TikToks, although my teens tried really hard to get me to participate in those, I did find myself in the middle of a massive project that was to build an online training course called ELSO Foundations. The global collaboration and innovation that occurred was truly extraordinary. While the end product was an online, on-demand course that was kind of focused holistically on adult ECMO concepts, the broader impact of this work is a validated, standardized curriculum for adult ECMO education. ECMO as a treatment modality, as we all know, has really exploded underneath us. So not just even with the era of COVID, and I still don't even think that we really understand what COVID did to the world of ECMO, but really with expanding indications, technology, and growing body of evidence, we've really watched it increase 10 to even probably 20-fold by the time that we tabulate the numbers of what really has happened with the era of COVID in there. So it's my hope that programs will view their training programs as not just a mechanism to train healthcare providers to do ECMO, but really understand the importance of the foundations of building a strong clinical program, really start with good ECMO training. So I have no financial disclosures, but I do have Venmo, which I went too fast. So if anyone would like to, I will happily disclose that you gave me money, but we'll see how this goes. So my ECMO journey. ECMO has been an incredible melting pot of people, and perhaps that's been my allure to why I got attracted to this crazy world of ECMO. Traditional medical conferences, you can imagine, right? You go to the very large, 10,000 plus, you get physicians going to the physician breakouts, nurses and RTs head to theirs, the perfusionists head to the bars, and then eventually, I'm not wrong, am I? I'm not, I really am not. But with ECMO, the constructs of the idea that ECMO is a team sport really revives through and through, and all of us coming together at the bedside really have been able to enhance and advance ECMO patient care. So again, probably why I've had such an interest in navigating that. And sorry, my mouse is going crazy up here. So I started my healthcare career as a neonatal ICU nurse. My first job out of school, bright-eyed, ambitious, ready to take on the world. But back in that era, I was working third shift, not night shift, third shift. So 11 to 7, so that bright-eyed, bushy-tailed part did not last very long. So there's a couple items on the screen that are just going to help you understand how many years ago this might have been. Yes, I did graduate and wear a nursing cap, and that is a silicone membrane oxygenator. So beyond that, you can do the math and try to figure out how long ago I did my training and what the era of ECMO looked like in my beginning. So it's in that ICU that I was first introduced to the world of ECMO. The visuals of seeing ECMO in action is almost a dream that I keep playing, a dream or a nightmare. I'm not sure on any given moment, but I do remember my preceptor walking me over to the other bay to show me a baby that was just placed on ECMO. And the picture above shown there really wasn't far off from what I saw, right? ECMO circuitry everywhere, machines everywhere, and somewhere in the mess of that was a tiny little baby that was put on ECMO. My curiosity was piqued. I learned at my hospital that nurses and RTs were trained to run the machine that inevitably was running the body. I hadn't even heard about this thing called ECMO in nursing school, so I was completely awestruck that they were going to trust nurses to do this. A couple years later, again, on a quiet night in the ICU, I was waiting for the delivery. I was part of the resuscitation team, so we were sitting outside the labor and delivery doors waiting to go back for a 23-weeker. And I was making small talk with the attending. They still came in for those deliveries, and I watched him down an entire pot of coffee as we were making that chit chat, and he's like, why don't you do ECMO? Why haven't you put your name in yet? And I really don't know if it was, his vote of confidence for him even asking, why I hadn't joined the team or not. Maybe it was still that twinge of excitement that I had when I thought about those cases that I had seen. But either way, I had that vote of confidence. I must have done the Stuart Smalley, I'm good enough, I'm smart enough, thing that decided go for it and join the team. Applied, was accepted to the team. At that time, to become an ECMO specialist, the training looked like pretty traditional, which probably isn't far off from what many people see today, right? It's a 4-day course offered at my hospital. When you're done, you sit 32 bedside hours. And that 4-day course consisted of me sitting in a tiny conference room. It was like experiencing death by PowerPoint, which I'm doing to you all now. Sorry, I don't know why it skipped there. And so, part of that course was taught by maybe, I think, 2 people throughout the whole 4-day experience. So it was, my experts were just a couple people that were going to teach me about what this whole thing was about. I don't know why this thing is skipping on me. You guys running it on me over there? All right. That's my penance for not telling you I had video in there. So part of that piece in there is that we went through our 4th day of the training. We were on the last day. It was time to do water drills. And of course, the pager goes off. We only have 2 ECMO pumps at our hospital at that time. And so the pumps end up leaving the wet drills. So I didn't even really get to see what an actual ECMO circuit looked like. I had only looked at them on PowerPoints. But at least I did get to go kind of sit in the corner and watch as they put the baby on, but never actually got to touch a dial, never touched sweep, never touched anything. But now that the baby was on, I was going to get some orientation time. So I did all 32 hours of orientation on that single case. Again, night shift. So what does that mean? Don't touch anything, don't break anything, don't breathe on anything, don't do anything until morning. So I finished all 32 of those hours mastering lab draws. That was about the only thing that we could probably do during that time. So draw some ACTs, draw some gases, pre and post. But I wouldn't even say I mastered that, because for the life of me, I could not figure out to remember to hold the syringe post-pump. And pretty much every time I would do post-oxygenator gas, I'd blow off the syringe and create a blood bath. And so even that, I wouldn't say I mastered. But I was officially an ECMO specialist, and as luck would have it, my very first night, independent, the pager went off. I forgot to mention, or if you didn't catch what Bill had shared, I started neonatal peds, pager goes off, and University of Iowa is going to put on their very first adult ECMO patient. Me, a NICU nurse, who doesn't even know where the surgical ICU is now running in to do my first shift independent. And I will never forget, it's like I was getting report off, and they're like, yeah, you'll be fine, it'll be great, take a breath, we don't know what the hell we're doing anyways, so just, you'll be good. So we were starting an adult lung transplant program, and so that really was kind of our parlay in. This was, I'm gonna show you my Midwest. This was a grain elevator injury, so he was crushed by grain and had pulmonary contusion, so we were putting him on. So in the subsequent years, I spent a lot of time reflecting on that training and preparation for the ECMO emergencies that I would see, and heck, the ECMO emergencies that I probably caused because I didn't know how to diagnose the problems in a timely manner. My curiosity for ECMO grew, and there's a profound desire to build something better. The training I experienced helped me build that basic knowledge level but the technical and applied cognitive skills just really were not there. So, you saw this screen briefly up there, but as you read the word pandemic, I'm willing to bet your mind immediately went to COVID-19, but guess again, my first go around of this happened years before with H1N1. You're also probably wondering, where is this beautiful tropic oasis? Yep, you saw that. Welcome to Iowa. Y'all are jealous that that's what I drive around to. So my early years of ECMO were largely focused on neonatal and pediatric ECMO, traditional meconium aspirations, PPHN, post-congenital surgeries, the good old days of ECMO, but that didn't last long. So the trends of what was happening with ECMO have been nothing short of astounding. Again, those of you who are sitting ECMO, adult ECMO in particular, this is not a shock to you. You see this line that is basically non-existent flat for decades. And about, if you can read the tiny script down there, clear down about 2009, you see the line for adult ECMO just simply going off the charts. And as someone staffing during that time, right, you saw each year tick up and you're like, okay, where's the ceiling gonna be? When's this gonna end? Where possibly can this go? So click to, again, 2009, and what I call the perfect storm. I will also show you my Midwest and say the memes are true. So when the sirens go off, I go outside, and so this feels like home to me that we truly do. That is 100% accurate, that I watch the tornadoes come in. But this 2009 adult ECMO perfect storm, what did that mean? So New Zealand put out their reports and said, you know, there might be something to this. I don't know if you guys are seeing this thing going on, but this flu seems to be helped and supported if you can go ahead and put your patients on ECMO. And so then everyone that did have an adult ECMO program started, okay, I really hope this thing doesn't come, but if it does, let's be ready. Then Dr. Peake was running around the UK at the time doing the Caesar trial, and any meeting that you may have gone to and or heard, everyone started growing that excitement, right? Everything was saying, hold on to your hats, there's something here, we're gonna publish, you know, we've been able to do this trial in the UK, and we've been able to show that there was a significant improvement if a patient went and was treated on the ECMO arm versus traditional mechanical ventilation. And then, not to endorse any one particular product, but there was a lot of technology changes at that time as well. So the McKay CardioHelp came out, dual lumen cannulas came out, and so all these things started to hit right at the perfect time that we started to see that surge. That was not me, I promise. I don't know what that was. All right, so I get it. I wasn't truly in the middle of nowhere, but with adult services at that time being very limited, right? So we're just at the crescendo of that trend starting to go off the charts. So there really wasn't a lot of us around, or at least I didn't know who my resources around were. So flash forward, and I'm going to tell you about November of 2010. So the weather in Iowa can be very unforgiving. You get the beautiful color changes in the leaves, but it's definitely, temperatures can start to get really cold, and I'll explain why I'm even telling you that. So I get a text message from a friend of mine, Melody, who's an ECMO coordinator at in Hawaii. So she shared that they have an adult ECMO patient that they were assisting with at Tripler, and it was looking like it was going to be a long run, and they may need to transfer out. She believed that they did secure a bed on the West Coast, but with my relationships of knowing her, as well as at the time the medical director, knowing my medical director, you know, we were there to support whatever they may need, and so we were in constant communication with them. And as you saw that little plane fly over, pretty much within 24 to 48 hours, I ended up seeing them show up in my ICU. So flying from Hawaii, next stop is that little tiny state right there in the middle. So needless to say, I mentioned the weather because they thought they were getting a bed in San Diego, and so under their flight gear were shorts, and I think they had flip-flops for their other pair of shoes and a t-shirt that did not hold up so well when I think it was 20 degrees when they landed at 2 a.m. at a municipal airport with a Gulfstream. And I'm not sure how many of you are familiar with the Gulfstream aircraft, but in order to get the patient out, I'm 6'1" with heels. So I even was staring up into how they were unloading this patient. So the doors pop open and we're sitting on the tarmac at 2 o'clock in the morning. And I'm not exaggerating that the shift workers there were, I think, some high school kids who we were like, okay, there's a patient up here in a big, if you guys have ever seen Hawaii's flight cart, I mean, it's massive and it's heavy. Trying to figure out how in the world we're gonna drop it about 8 feet down to the ground to help get this patient out. No ramp, no way to do this, and if you saw that quick little picture in there that jumped, yeah, we used a forklift. So it was moments like this where I began to realize the unique world that I was truly a part of. Resources and expertise might be a phone call away, but also perhaps 2,000 miles away, and required you understand how to drive a forklift in order for you to successfully navigate it. You know, I was a small volume program even at that time. I was doing 10 to 15 cases a year, and all of a sudden I was supporting 3 to 4 patients at a time. I needed equipment, I needed staff, and the solutions to obtaining them during the first go around with the pandemic, it was nearly impossible. That was the horrible time of trying to navigate the disposable shortages and trying to figure out where you were gonna get your next batch of oxygenators or circuits. There's nothing worse than willing an oxygenator to work just 12 more hours because you expect the delivery to come in on the next shift. Or perhaps you're napping in the hospital waiting room because you know that there's no other staff to relieve you, you've got multiple cases on, and so you can't go too far because you need to make sure that you've got the team has the support that they need and people readily available. So when COVID started to hit, I saw history beginning to repeat itself. I knew I didn't want to be without equipment, staff, but what was I gonna do different? Luckily by this time, my ECMO network started to grow. I had relationships and friendships. I had friends that were in surrounding states that, you know, could be a 4 to 5 hour drive away if anything was needed. But then the dark days hit. As I'm sure you recall, all of a sudden states were shutting down at the state lines, systems were overrun, and so it really was a fend for yourself attitude. If ECMO beds were filled for me, my friends in neighboring states were not gonna be able to help. I was facing the reality that I was going to watch patients die due to lack of access to something that I knew had a chance to help them. When COVID started taking 30-year-olds and 40-year-olds, it almost became unbearable. What might be even more unbearable is the fact that this keeps jumping on me. I don't know what I said on here, so I apologize for that. So at my peak with COVID, I was supporting 6 patients on ECMO. And you know, those peaks, as we all know, right, they lasted months, not days, not weeks, months. And for some of us, I think we're still, I'm willing to bet many of you still have some of your COVID ECMO patients that are still on today. So we're far from the end of this battle. So you've stared at Iowa. My goal in here, the subliminal part, is you'll never forget where Iowa is. But you've also probably picked up on the fact that there's some pin drops on the state. So those pin drops, so I'm where the red little drop is there in Iowa City, so off on the eastern side. And I'm ashamed to admit, you know, I never really acknowledged the other centers. They were competitor hospitals, right? So evil hospital administrator, even more so, not really acknowledging those competitors. I had an elitist attitude. How could they possibly be as good as the University of Iowa? We've been doing ECMO the longest, blah, blah, blah. But with resources so scarce, with me not really knowing where this pandemic was going, I did the unthinkable and I reached out to my competitors. And my computer keeps skipping. Maybe. Or I can just have fun and we'll just never know when it flips over and you guys can get a sneak peek of where I'm going with this next. So you know, I reached out. They were just as scared and just as overwhelmed as us. So I connected with one of the programs in the middle of the state. They had contacts to some of the others. And what started as a Zoom call turned into weekly calls. I think part of it was kind of our group therapy session. And then we ended up going on to the group chats. So we created on WhatsApp Iowa statewide group where we would report out volume updates, equipment status, collaborate on any of the calls that we received out of state. You know, as an individual program, I felt like I could support 6 patients at a time. And our teams collaborating together, though, when we started to pull all of our resources and count how many pumps we had, we could double our capacity, and we knew in the state we could hit about 12 and still feel like we were open and being able to support others. We created statewide selection criteria for COVID patients, and we agreed we were gonna all stick to the criteria, or we were gonna send a consult out, and that if we were gonna consider exceptions to what we all agreed to, we were gonna get on there and discuss them together. We started to notice programs kind of cherry picking, so they'd call one and tell a slightly different story, and I get it, right? We were all in a really bad place, and people thought, you know, they wanted to get their loved ones to an ECMO center, so it wasn't just other hospitals, it was family members calling us and sometimes calling all of our programs saying, can you please take my husband, can you please take my wife, can you please take my child? So, you know, we really did see it our collective mission to serve as many of our native Iowans as we possibly could, especially as the state lines were closed and we knew we were really kind of in it together. And of course, Christmas night, we got an in-house consult for a patient that was deteriorating. We had 5 patients on pump and a 6th pump that just had broke that day, so we were kind of stuck. And it's Christmas, so what do? You know, this patient was young, had no other comorbid conditions, and so we started making the calls, sent out a chat, and so 20 miles north of us, a center had one of their systems open, and on Christmas night, I got a delivery of an ECMO pump within an hour of putting the call out, and we were able to offer support to that 6th patient. That relationship has evolved over time. You know, those initial group chats had turned into, you know, if we could agree to policies, if we could agree to consults and how we were going to evaluate patients, how could we support what we were all facing, which was staffing turnover? So how could we continue to work on that staffing element? We knew that, you know, running an ECMO training course is not an easy feat. You know, arranging your speakers, being able to get the sim room set up. You know, it's not just like you can snap your fingers and everything's ready to roll. But we started to think, you know, if we can agree to these clinical management pieces, if we get our physicians to agree to our clinical management pieces, the conversation naturally evolved to, well, what do you do for comps and what are you teaching in your course? And why not, you know, if we can do it once a year and you could do training once a year, is there a way that we can have an onboarding process multiple times statewide if we're teaching the same and supporting each other? What would that look like? You know, I think then for us in Iowa, it's still kind of an evolving process for us, but with newly released ECMO curriculum that I'll talk a lot about, and a certification process, at least we have a place to start from. It'll allow our programs to be able to bring on specialists more than just the once a year that we're doing now with our traditional model. And in concept, right, that sounds wonderful to be able to onboard on demand when you need staffing. But how can this be put into action? And I hope I've enticed you enough to keep listening so I can tell you how. So to fully appreciate the magnitude of the educational initiatives, I wanted to back up a bit to where we really started to gain momentum with this. So a few years ago, ECMO education enthusiasts converged to Santiago, Chile. This task force we now call ELSO-Ed consisted of 40 healthcare practitioners from 19 countries. The distribution of where and what those people came from, so it kind of splits down the different ELSO chapters, so we really did try to keep it balanced amongst the different parts of the globe. And while we had, I know it's kind of blurry, the biggest group were intensivists, we really tried to make sure nurses, RTs, perfusionists were also well in the mix for that group, so it shows you there. A piece that I do want to stress though is invitation to this gathering was heavily weighted on practitioners that not only had ECMO experience or significant ECMO experience, but people who had formal and informal medical education backgrounds as well. So it was people who were really passionate about navigating ECMO education. So the focus of the gathering was twofold. So we were in beautiful Santiago, Chile, but we had homework to do. So we sat in some conference spaces for a couple days and really started to hone in on describing the state of ECMO education worldwide. And then our takeaway was to create an agenda looking at those opportunities for this standardized global collaborative approach towards that standardization of curriculum. And then that's the basis for the paper that you see at the bottom, that this team was really coming together to create a roadmap for what was really needed in the realm of ECMO education. So the crazy group at the bottom, I'm somewhere towards the bottom of the steps in that group. So we were divided up into 7 teams represented on screen. Each team was handed an overall objective to work towards, and then or an overall task to reach those. So the blue was really the content generation process, right? So the curriculum committee was truly puristically that, come up with what criteria that curriculum should be presented. The red in there was really how are we going to deliver that content. This would be the pedagogical approach to how we're going to navigate that, and I'll go into that approach a little bit later as well. And then the black is the quality assurance pieces. How are we going to assess the impact of ELSO's educational pieces in there? And that was the desire to create a more sophisticated feedback loop that will allow our teams to say, you know, did we teach what we intended to teach, and to what degree did we do so? And that would go, our desire was to design a system that was beyond the proverbial subjective feedback form that I'll say, if you don't want to give John 100% on, you can give me all 5s, because I know you'll get the report here and have to say who's getting what scores. If you don't want to give me a 5, you can meet me outside afterwards and I'll explain to you why you're wrong in that approach. So let's just get that out of the way too. So with creation of the validated knowledge assessment tool, as well as a psychometric skills checklist that we have under development, we have access to data that will allow this continuous process improvement wheel that we can look at our educational approaches in the realm of ECMO. So I will, again, because a lot of the work was heavily weighted in this curriculum piece, just kind of explain to you our approach in there. So we use Kern's model, which is a well-established framework on curriculum development. And the expert panel was selected to review this comprehensive list. So this is kind of how we whittled down to what exactly should we be teaching about ECMO. So the panel was given a full list of learning objectives. And it's a team, again, 12 people, multidisciplinary in nature, global representation. And they used a Delphi method to prioritize those learning objectives. So they were first asked on a Likert scale to determine the importance of each. Unimportant learning objectives were weeded out. The more important it was, the more that they kind of flagged those that inevitably went into what they would use for a certification exam. And the product of the work ended up being 9 sections, 53 modules, or you could call them module titles. And in there, about 80 learning objectives that now are what really are the makeup of the core curriculum. So from October 2020 to December 21st, another multidisciplinary team took the list of core curriculum and transformed that into the piece that is called ELSO Foundations. And maybe by the end of this talk, it'll stop skipping on me. So I will show you a little preview about what the course is and be able to describe a little bit more of what ELSO Foundations looks like. But before jumping into that, I'm going to take a time out here. So, hoping everyone, granted I don't have my glasses on, so people in the back could be sleeping, but I don't think I've lost anyone to sleeping yet. So is house engagement. I'm not seeing a lot of phones out yet, so that's also a good piece here. So I do want to ask the question though, what's the average attention span of an adult? Who thinks, I know, right? 5 seconds, a gnat. How about an hour? Who thinks that the average attention span is an hour? Really? Okay, well, you got a few. Thank you for being brave and choosing that. You're wrong, but it's, how about 30 minutes? Half an hour. You guys don't think adults can focus for 30 minutes? All right. How about 20 minutes? Okay, get more hands. How about 5 minutes? Yeah, it's feeling like that, right? All right, so according to most studies, the average adult maximum attention span is 20 minutes. So you can choose, what I find interesting in that, right, is individuals can choose to refocus their attention multiple times on the same activity repeatedly. It's normal to lapse in attention during that to occur, but by my math, based on how long I've been given to do this talk, I'm going to lose you at least twice during this period. So no offense taken, you're just being an average adult, that's fine. So after 20 minutes, lectures do become less effective. And it's important to know these things, right? As you're out there and teaching these concepts, just realize that if you're teaching to normal adults, that is the reality of what's going to happen. So working memory and interference are the problems. So as learners encounter unfamiliar information or exposed to new concepts for the first time, their working memory has to process that input. So these require attention and ability to focus. As a lecture progresses and the learner continues to get bombarded with new information, they try to process it. So that whole concept of information overload is absolutely a real phenomenon. The decreased ability to effectively incorporate new information is called interference. So it makes longer lectures both less enjoyable and less effective. So I am really sorry, guys, because you are stuck with me for at least 40 minutes. So we'll try to work on this. So if the phenomenon is widely known, well-published, well-studied, then why in the world do we continue to do lectures as the primary method of conveying information to groups? It's really been this way since the Middle Ages, and we have not evolved beyond that. So how do we remove beyond the constructs of this idea of sage on the stage, right? The idea that the lecturers are the all-knowing, all-powerful, I am here to transform your information and bestow upon you all the knowledge I have. We already know that the failures in this pedagogical form is numerous. Many times the lecturers are only going to teach what they find elegant or pleasing, and they're not going to touch the stuff that they find to be difficult or complex. So who really enjoys teaching about clotting cascades and its activation in the extracorporeal circuit? I sure as heck don't. And so if you give me that title, you are in for quite a doozy of a talk, because I'm not going to probably do it justice, because I don't even have a concept of what I'm trying to teach you. Probably wrong audience. You probably all love that stuff, so I probably just sold it to the wrong group. So some educators and experts have questioned whether in this modern era is technology having negative influence on the students' ability to focus, and the answer is it's mixed. So while students have the same ability to focus as previous generations did, they are accustomed to that constant barragement of text messages and medias, and you just have to look at how fast-paced things are. So the interesting though is it doesn't mean that they can focus any less, the inputs are a little bit more impactful on them. But they've also though developed a preference for faster-paced, interactive learning material. The potential distractions, they're different than they were decades ago, but they're not really changing our attention span or lessening our attention span. Also, nobody really wants to lighten coursework so much that students are going to miss important concepts. So the new emerging training process is this micro-learning concept. So it allows educators to break comprehensive, in-depth courses into much smaller pieces. So each learning element should only take between 5 and 15 minutes. It should be short, have hyper-focused bursts of learning, and these micro lessons can be enforced by administering assessments or knowledge checks throughout to make sure that they're really retaining and having more information in there. So I say this because you'll see that translated to our interpretation of that in ELSA Foundations. So another popular movement is flipped classroom style. So a lot of the work then is happening outside the classroom. You're going to give them videos to watch. You're going to give them text to read. So that way then when the students come into the room, you can have a far more enriching experience beyond just the stage and the sage on the stage where you're teaching the knowledge. You're really getting at that point the students to teach you what they learned in those sessions. To make it far more of a dynamic and enjoyable experience for probably the students, but probably you as a teacher as well. And I think that we've been able to see that in action. Over the last 2 years, I became a 9th grade, 7th grade, and 3rd grade teacher too, right? Because most of us had to deal with online learning as we sent our students home. And so I think the advances in the style of remote learning and being able to really have a different paradigm in how we're teaching has really escalated and proven that it can be done and it can be done well. Although we'll see how my kids' standardized tests come out to see how well I actually did teach them those things. But again, some of those pieces in there really put down to time, length, attention, focus, keeping it that 5 minutes to maybe 15 minutes, and that's all you're going to get if you really want to get good learning to occur in those periods. I know that our keynote talked a lot about TED Talks, and I'm a sucker for them as well. And you know, even short presentations can be really boring, so I was really interested as I was doing the work to try to help the editorial group really kind of synthesize what we were going to do with ELSA Foundations to say, what is this thing about TED, and what can we steal away from TED Talks that might help us? And you know, I think that for any of you who got sucked into those, you realize that there is something really attractive about watching a TED Talk. So I'll share kind of some of the pieces that come out of there as you approach future lectures and topics to see if you can adopt some of these things, because I do think there's a lot of places in our training that could benefit from these. So TED Talk presenters tend to be conversational. They remove any barrier, so no lectern, I'm messing that up, no handheld notes, which I'm trying very hard not to use, but really it's turning into more of a conversation so that you're connecting and engaging with your audience so that it's not just a sit and stare at my presentation and read what I have on my screen. So it helps to make sure that you can really engage, excite, navigate that way. Be concise, don't ramble on, get to the point. The type D, if you've ever had the personality type piece in me, like I like bullets, I like get to the point, maybe why I enjoy TED Talks so much. But those actually, they say they cannot exceed 18 minutes, which is probably back to the first piece of just attention span. But it really pushes you, and if you've ever been told that you have a topic and you have to present it in 15 minutes or less, it really makes you do your homework and think through exactly what do you want to teach, how do you want to teach it, and I think that there is something to that concise piece. Share compelling content. So again, the piece in this is, you know, be compelling, be exciting, try to figure out not only really what's the important piece that you need to teach, but also teach it in an idea worth spreading kind of way. Anyone can pick up the textbook and read about ECMO physiology, but what do you want to say about it that they couldn't have just read in the textbook? That's really the key ingredient here in being able to navigate it that way. Coaching, and that really is just kind of a no-brainer piece in there, is don't ever show up on a lecture without being adequately prepared. Give it a couple times, let people critique you, and so TED Talk people will say, you really should have presented it several times prior to going up, and I think that just goes without saying, but they had enough that they put it out there as part of their standard curriculum of what is required for their talks. And then the last is be the central messenger. So with TED presenters, the presenters are usually the centerpiece. So if you've ever watched them, you'll realize there's not much going on in the slides other than what our keynote did a fantastic job of too, right? It's use the visuals to supplement, but the story is being told at center stage. And so I think that as you get into meetings, and there's a difference between a scientific presentation and one to engage you. So I get, if any of you are doing talks and you're sitting here going, I have a ton of words on there, there's a difference between presenting scientific information and engaging your group. But if I'm puristically speaking about ECMO training and how we're going to train the next generation of ECMO practitioners, the reality is that we're going to have to hit them in a couple different ways in order to get the information across. And I'm not really sure the scientific method of delivery. They can read the papers, they can read the textbooks. We're here to teach them and have it resound in a different way. All right, so back to that sneak peek that I was talking about. So ELSA partnered not only with clinical experts from around the world, but we also really spent a lot of time thinking about who our partner, our IT partner was going to be. So we ended up grabbing a group called Sweet Rush, and they ended up taking our 50 clinicians with their team of 20 instructional designers and creative designers to help us create this micro-learning course And I say that because, as you'll see here in a second, I'll show you our dual circulation on differential oxygenation. It's, I think that one is 11 minutes. I'm not going to show you the full 11 minutes because I just started to get the early, you're about done message. But I will show you kind of a sneak peek of what that visual looks like. Fingers crossed.
To demonstrate the physiology of differential oxygenation, let's look at blood flow during different physiologic conditions. In the first, the patient has just been placed on peripheral VA ECMO, and the left ventricle is not ejecting. The blood being returned into the femoral artery is well oxygenated and travels retrograde up the aorta to supply the brain and heart. In the second, once there is some left ventricular recovery,
Yeah, that's what it was on. This is the point where I wish I had like good jokes or something, but that's just not in my forte. I'm a dancer. Yeah, I could soft shoe up here. Let me try to see if I can hit play again.
Well, usually it pops up the little menu.
blood will be ejected by the left ventricle and grade into the proximal aorta, while the ECMO circuit will continue to supply blood retrograde up the aorta. The mixing point is the location in the aorta where the two blood flows meet. The location of the mixing point can be anywhere along the aorta. Competitive flow describes the dynamic nature of the mixing point based on the relative pressure of each source. Note that if there is good gas exchange in the native lung,
I was joking but not joking in that I do think that actually the way that the
to demonstrate the physiology of differential oxygenation, let's look at blood flow during different physiologic conditions. In the first, the patient has just been placed on peripheral VA ECMO, and the left ventricle is not ejecting. The blood being returned into the femoral artery is well oxygenated and travels retrograde up the aorta to supply the brain and heart. In the second, once there is some left ventricular recovery, blood will be ejected by the left ventricle antegrade into the proximal aorta, while the ECMO circuit will continue to supply blood retrograde up the aorta. The mixing point is the location in the aorta where the two blood flows meet. The location of the mixing point can be anywhere along the aorta. Competitive flow describes the dynamic nature of the mixing point based on the relative pressure of each source. Note that if there is good gas exchange in the native lungs, the whole aorta.
So it's been ELSO's long-standing recommendation that ECMO training be focused on creating a pathway to navigate the first 3 levels of Miller's pyramid. So George Miller was like in the 90s. His whole claim to fame was, we can't just, again, it's kind of back to the pedagogical forums, you can't just teach the stuff out there and assume a knowledge transfer is happening. He felt like, especially in medical education, we need to have better systems in place that we can actually watch them in action and watch them in a place that they can actually take that knowledge and apply it to this cognitive and skill placement. And so what he did is kind of laid out the framework of, sure, I can have you read the book, I can give you a lecture, and I can do a multiple choice question to say, did you understand that? And as you go up the scale, it's implied that you're really actualizing and being able to take that information and transcend it into the bedside placement in there. So some of the things that also came about with the curriculum is I quickly mentioned that we wove it into the learning objectives. So the expert group that said, hey, these learning objectives, like if you don't know this, you probably shouldn't be doing ECMO. All those learning objectives were given to multiple choice question writers or authors that were able to take those learning objectives and translate them to questions. And what that ended up turning into was about 120 multiple choice questions that are focused on adult ECMO that now are a certification exam that's linked directly to that core curriculum. For those of you who like understanding exam design. Here's what this whole feedback looked like to really create those learning objectives, write the questions, create the exam blueprint, review, and then the last probably 18 months we've been doing the psychometric analysis on it, and then in January it officially launched. If you have no desires to know about exam cycles, I've just lost you for the second time and you guys have totally blanked out on me, but there are people that do enjoy the concepts around exam writing, so that shows you that piece. And then the three-step piece in there is that really a prerequisite. People always ask, you know, how do you take the exam? There's an application process. Have you gone through training, yes or no, and what did that training include? Have you done bedside simulation training, yes or no? And can you write a letter or have someone write a letter that says you've done bedside experience? It is that simple to be able to go through that, but we're just trying to understand the learning elements in there. So why is standardization so necessary? Why did we even attempt to have this conversation? And I understand that, you know, sometimes standardization can be said, you know, it looks negative, right? It's a cookie cutter approach. But what I will say is that, you know, if you really are thinking about standardization in healthcare, it really is going to minimize that risk of error, increase patient safety, but it also is going to really help with innovation. And I say that because how many people have written a presentation on circuit components, physiology, all the things that I'm sure all of us have, and then, you know, we've probably stolen them from somebody else, and then we've remade them on our own, and that's, you know, time that could have been spent in the innovation phase of why create something that is a scientific basis piece. If somebody can create something in a medium that can be reproduced and shared, then we can spend more time trying to figure out how to translate that information in other ways to our learners. So definitions. So part of this is I just bring this about is to say, you know, what is a nurse? So I'm sure a mental model for you pipes up and you know exactly what a nurse is. How about a doctor, a respiratory therapist, a perfusionist? You know those roles. We've had this definition of ECMO specialists out there for quite some time. And I think it's, you know, kind of that globally accepted piece in there. But I bet if we started to go back again and for those same roles started to say, what is that training, what does that training look like? And I'm sure even in this room, if I started to survey, what did it look like to become an ECMO specialist? Sure, there'd be themes the same. But I bring this up because the trend that I'm watching emerge that I'm excited about, terrified about, probably all in once, is go to LinkedIn. Not now because you have to focus on the presentation, so I'll do that for you. But LinkedIn, so right now what you're finding is a ton of job for ECMO specialists, which I, you know, have my own job up there for ECMO specialists at the University of Iowa. But I say that because I'm a little terrified with that one because I'm hiring someone who I don't really understand completely their background, but I actually started having LinkedIn ping me every day. There are 30 new job openings for ECMO specialists every day on LinkedIn. And so I know what it is to be a nurse, and in the US there's a standard that I had to go through a standardized curriculum to sit for an NCLEX exam to get my license. But what is there in existence for ECMO specialists? Same thing here. We've had this question come up recently is how many hours should a perfusion student, so these people are going into the world to be perfusionists, how many hours should they sit pump independently to become an ECMO specialist? Or to be able to graduate, I shouldn't even say to become an ECMO specialist, but to graduate. Right now, the standard is not there. I think that we probably could ask what our schools are doing, and there's probably similar numbers, but there's not a standard, and these people are going to get hired in these roles. That in my own hospital, when ECMO didn't work out, they'd go back and work in their ICU, but now these people are changing states, changing jobs, changing hospitals to work in this role, and I think that that just even necessitates it that much more. Just with the interest of time, just because everyone loves the Joint Commission, I say this is also another reason why standardization is so important. You can't be prepared for something by still wishing it would not happen. So I had last triennial visit, day 2, a surveyor at the beginning says, let's shake things up. Do you guys have an ECMO patient in-house? And I sat there like started to immediately sweat. And he's like, I'd like to go to the bedside. I'd like you to pull for the credentialing session. I want whoever the managing physician is, I want their files, and I want the files for the ECMO specialist. So For me, like, I did sit there and I was like, okay, do I fake that I'm having a heart attack right now? Because I'm not so sure I'm not. Do I start frantically texting the bedside to say, please take this patient off now in the next 5 minutes? Like, whatever you gotta do, just get them off. Hide the drinks, because that's all they care about. So maybe like if all the drinks are covered, maybe they won't recognize the ECMO patient in there. Or I could just take a breath and realize, you know what, I got this, which I did. But there's overachievers in our world everywhere. And you know, in this room probably even, there's somebody that has a 15-page checklist of all the technical things that it takes to be an ECMO specialist. And then there could be you who has a paper that says, this person knows ECMO, signed your friendly ECMO coordinator. So if you're Joint Commission and you go to Hospital 1 with a 15-page affidavit and blood work and fingerprints on one ECMO specialist, and now you're sitting there going, I just signed and said, yes, they know ECMO, we may have an issue. So regulatory groups are asking, regulatory groups are interested, and I don't think that's gonna change anytime in the future, and even dear CMS and Medicare has looked at us, so I don't think that's changing either. So I think it's probably time that we go back and really think about what our training looks like. So ECMO 1.0, right? We all know what that looks like. Early days of ECMO, complex circuitry, constant vigilance at the bedside, make sure nothing explodes, make sure nothing sucks air. ECMO 2.0, that got us doing the fun of walking around our ECMO patients. They're awake, they're talking to us. It's been an exciting ride. I do want it to go on the record that I'm calling ECMO 3.0 right now. We did a lot of crazy stuff in the pandemic. A lot of crazy stuff with these ECMO patients that, you know, actually ended up working out and ended up being just fine. So what surprises are ahead of us, and what will the next few years bring? Do you have your team trained? What does your training look like? How long is your training? Is your training gonna stand up to the training program that's down the way? And really trying to think through that the teaching does matter if the end game is knowledge transfer. So I really challenge you to think long and hard about how you're getting your team ready for this next paradigm. And before Bill gives me the official hook, I'll end it and say thank you. My email's on there, and if you'd like to see the video, I'll be at the bar.
Beautiful. Thank